Hello, everyone. Thank you for joining today's rescheduled public webinar providing an overview of the 2022 Quality Payment Program Final Rule. During this session, CMS will provide an overview of the finalized policies for the 2022 performance year of the Quality Payment Program. CMS will take as many questions as time allows during the Q&A portion at the end of the presentation. Please note, we will not be monitoring the chat box during today's webinar, so please submit any questions via the Q&A box. Now I will turn it over to Katie Moore, Health Insurance Specialist at CMS, to begin.
Great, thank you, Haley, and good afternoon, everyone, and good morning to any West Coast friends we have on the call today. So thank you so much for joining. As Haley said, this is going to be an overview of the final policies for 2022 for the Quality Payment Program. And if you all joined us a couple weeks ago now, again, apologies that we had to reschedule, but thank you again for joining in today. We have all of the SMEs on the line again today, so hopefully we will get to as many questions as we can once we get to the QA. We have a lot of information to go over with you all, and hopefully at this point you've had a chance to go through the rule or some of our plain language materials that are available, so you have some questions ready for us today. And again, I'll just repeat what Haley said for folks. At the bottom of your screen, you'll see a QA option and a chat box option. We will be using the QA function to respond to questions throughout the presentation and then at the end during the Q&A session. So please use that, that option. We can go ahead, I think, 2 slides, Haley. Great, thanks. So it's just a quick rundown of what we'll be talking about today. So we are going to go through our Quality Payment Program policies that were finalized in the 2022 Physician Fee Schedule final rule recently. And specifically, we're going to go over traditional MIPS, the merit-based incentive payment system policies, get into more detail about the MIPS value pathways, so our MVPs. We're really excited for some information there. We'll touch on public reporting changes and then transition over to our advanced alternative payment models policies, or APM policies. And then we will finish up with our Medicare Shared Savings Program and APM Performance Pathway, so APP. So a lot of information today, and then we'll finish with pointing to some more resources or where to go for help and support, and then get to the Q&A session. Next slide, please. Great, and thank you for sharing in the chat that the sound sounds good this time, and we're coming in loud and clear, so appreciate that feedback. So this slide is just a couple of reminders, and sorry, we forgot to delete the first one because that deadline actually occurred yesterday, but just wanted to flag for folks that there are a couple of things that we still have outstanding open until December 31st. So for 2021 performance year, if you need to submit a promoting interoperability hardship exception and or an extreme and uncontrollable circumstances application, please do so by December 31st. And also, if you are intending to participate as a virtual group for 2022 performance year, the deadline to make that election is December 31st as well. Next slide, please. Okay, and I think we probably got through this slide last time too, but just wanted to highlight again for everyone that we recently also announced that we are applying the MIPS, the merit-based incentive payment system, automatic extreme and uncontrollable policy circumstances policy to all individually eligible MIPS eligible clinicians for the 2021 performance year. The automatic EUC only applies to MIPS eligible clinicians that are participating at the individual level, so it does not apply to groups, virtual groups, or alternative payment model entities, so APM entities. And we have a lot of additional information that spells out all of those differences on our resource library, in our different fact sheets that are available, and as well as we have an exceptions webpage on qpp.cms.gov. So encourage folks to go look there for more detailed information about that policy update. Next slide, please. Okay, so here's just a list of all of the QPP specific final rule resources that we have available in a zip file on the QPP resource library. This zip file contains an overview fact sheet, as well as a policy comparison table that lists all of our finalized policies from 2021 and how they're different in 2022, or not different, but just lays that out so helps people understand where changes are happening. And then we also have a similar policy table that's specific to our MIPS value pathways. So it's overview of policies, changes that we're implementing, and then also what MVPs are available in beginning in 2023. And then also in there, we have a number of frequently asked questions. So encourage folks to check there for more details if you have specific questions, or bring them here at the end today. I think that is it for our resources. So I'm going to go ahead and turn it over to Molly McHarris to start our overview of our policies.
Thank you, Katie, and thank you again, everyone, for being here for our take 2 of our 2022 Final Policies webinar. Okay, so just first I want to start off by touching on some of our policy highlights. Again, you'll be hearing about all of these in more detail from many other folks during our time here today. But to start off with, some key changes we made for the 2022 performance period, which has payments associated in the 2024 year. First, we finalized our proposal to expand the definition of who is MIPS eligible to also include clinical social workers and certified nurse midwives. So those clinician types would be eligible to participate in the program beginning next year, assuming they meet the other eligibility requirements, such as surpassing the low volume threshold, et cetera. The second item in regards to the MIPS performance threshold and additional performance threshold, we did also finalize these as proposed. I do want to note that we received a number of comments from all of you asking us to finalize a lower value than the 75 points. We did take a look at this, as I'm sure you all saw within our written comment responses in the final rule, really in every way possible to leverage any available flexibilities we have. And unfortunately, we were not able to finalize a lower value. The statute, the law is pretty specific, where it specifies that we need to use data from a prior period, either using the mean or median. And so 75 points was actually the lowest value we could have finalized for the performance threshold. So again, we do appreciate all of those comments, but we unfortunately were not able to finalize anything lower than that. And I'll talk about this in a few upcoming slides, but as a reminder, the performance threshold is the numerical value between 0 and 100 points that clinicians want to achieve, because if their final score falls below that, they would get a negative payment adjustment. I also want to highlight that this will be the last year for the additional performance threshold for exceptional performance, that extra bucket of 500 million that we can distribute. 2022 will be the last year that we will be able to do that. And then lastly, we had previously finalized that the quality and cost performance categories would be set at 30 points each as required by law. We also similarly received a number of comments asking us to not proceed with this, to continue to have cost at a lower weight and quality higher. But again, similar to the performance threshold, from every angle that we were able to take a look at this, we were not able to find the legal flexibility to proceed. Beyond those items, we did also make some revisions to our quality scoring policies. Many of these included updating our transition policies back when we initially created the program. So first, it includes removal of our quality bonus points specifically removing our outcome high priority measure bonus points and our end-to-end electronic reporting bonus points. We do still have bonus points available if you are part of a small practice under the quality performance category under MIPS, but these other bonus points, we feel that they've served their purpose, and we will take a look at introducing additional bonus points or other scoring flexibilities in the future based off of those future priorities. We also introduced a scoring floor for new measures, and we revised this based off of many of your comments to have a higher scoring floor for the first year, where it would be at 7 points, and then 5 points for the second year. Some of the common questions we've gotten around this is, can it be applied retroactively? No, this policy will not be. So the 7-point floor would begin for measures that are newly available beginning in the 2022 performance period and moving forward. And again, we'll be talking about this in more detail throughout the presentation. Next slide, please. Some additional key policies for this upcoming 2022 year. We finalized the extension of the CMS web interface under traditional MIPS for MIPS groups just through the 2022 performance period. And then we finalized a longer transition for Medicare Shared Savings Program, ACOs, that are reporting through the APP, where the web interface would be available through 2024. We did receive a number of comments requesting a longer extension as those SSP ACOs reporting through the APP transition to reporting on ECQMs and MIPS CQMs. So again, the web interface will only be available for those SSP ACOs through 2024. Next slide. And then for the key policies we finalized for 2023 and beyond, you'll be hearing a lot about this later on, but the introduction of our MIPS value pathways, we are very happy that we were able to finalize all 7 of our proposed MVPs. This reporting option will become available beginning in the 2023 performance period. We also finalized a number of details related to MVPs, including how people can participate, what the requirements are, how subgroups could register, and we also delayed, apologies about the background noise. Okay, sorry about that. We also finalized with a delay the ability for multi-specialty groups, rather when they would be required to form subgroups until 2026. And then the last item I wanted to touch on, also in relation to our quality scoring policies, is that we delayed the removal of our 3-point floor. This is our last transition year policy. So this policy is still in effect for 2022, but beginning in 2023, the 3-point floor would not be available for instances where measures can be scored against a benchmark, they don't have a benchmark, or don't meet the case minimum. Okay, let's move on to the next slide, please. And next slide again. Okay, so just a bit of background information on the basics of MIPS. So as many, if not all of you know, MIPS is a performance program that assesses clinicians' performance in 4 distinct areas. That includes quality, cost, improvement activities, that deals with improvement within your organization, and promoting interoperability, which deals with the usage of certified EHR technology. I do want to clarify that all 4 of these categories are required by law. Some of the comments we received through this past year have led us to believe that people may not have fully understood that point, and that some people thought that we would be able to eliminate some of these performance categories as we move to MVPs. We are not able to do that, since all 4 of these categories are required by law. When we look to MVPs, we are looking, however, to make the reporting experience feel much more cohesive across these 4 areas. Again, when we look at these 4 areas, you can see that these each have a value associated with them. That sums up to a total of 100 points. We assess your performance on each of those 4 areas, and we provide to you a numerical value called a final score, which can range anywhere between 0 and 100 points. For the 2022 year, you want your final score to be at or above 75 points, because that means that you would be getting a positive or neutral adjustment. If your final score falls below 75 points, you would be getting a negative adjustment. Next slide, please. And again, just information on our performance category weights. The dark blue columns is what was finalized for 2022. The major change is really on the most left-hand side, which I've already gone over, which is that quality and cost will now contribute 30 points each. Next slide. And then, as I mentioned during our highlights, we also updated who is eligible to the MIPS program to include our clinical social workers and our certified nurse midwives. These are the last eligible clinician types we could add to the MIPS program. Next slide, please. And next slide again. I'm just going to start talking about some of our quality performance category policies. So just as a reminder of the basics, under quality, your performance is assessed on a 12-month period. For the vast majority of clinicians and groups, you would select 6 measures. Of those 6 measures, one would need to be an outcome measure or a high priority measure. You also could report and achieve this 6th measurement by reporting through a specialty set, or if you are a group, you could participate through the CMS web interface and report all 10 CMS web interface measures. Again, as a reminder, this last option will only be available for groups under MIPS for this upcoming year, 2022. After that, those groups would need to find another available reporting method. Next slide, please. Some other quality performance category basics. We have about 200 quality measures. The updates we made this year included updates to about 87 existing MIPS measures, which could have included substantive changes such as revisions to the measure title or the denominator, et cetera. We also made changes to our specialty sets, including removing measures from certain specialty sets. We removed from the program overall 13 quality measures and added 4 new quality measures, including 1 new administrative claims measures, which is focused on multiple chronic conditions. Next slide. And then, as I've mentioned a couple times here today, and you'll hear later on from my shared savings program colleagues, again, we finalized the extension of the CMS web interface for traditional MIPS groups through calendar year 2022 only. For shared savings program ACOs reporting through the APP, again, you will have the web interface available to you through the 2024 performance period. So beginning in calendar year 2023, MIPS groups would need to report through a different collection method type, such as working with a registry or reporting on ECQMs, or just reporting directly to us. Beginning in 2025 is when the shared savings program ACOs would need to comply with the other requirements that exist in the APP, such as reporting on either the ECQMs or MIPS CQMs. And let's move on to the next slide, and I will turn the rest of these upcoming slides over to my colleague Zenobia Raspberry. Zenobia.
Thanks, Molly, and good afternoon, everyone. So I will be talking through some of the changes we made to scoring of the quality performance category for the 2022 performance period. So beginning with quality measure benchmarks, you may recall that historically we calculate historical measure benchmarks from a baseline period that is 2 performance periods prior, which means that for the 2022 performance period, benchmarks would be calculated from 2020 data. So we made a proposal this year to use some alternative baseline periods or a performance period benchmark. However, we did not finalize these proposals because the analysis of the 2020 data found it to be reliable. So for the 2022 performance period, we will be using historical benchmarks calculated from 2020 data. We will post those benchmarks to the benchmark file by December 31st. We're also instituting a more rigorous QA process prior to publication, which should reduce the need to make updates to the file for the performance year. Next slide, please. Data completeness refers to the volume of performance data reported for a measure's eligible population. The eligible population is specified in the measure specification, and currently our policy is to, there is a requirement to report for at least 70% of this eligible population. We are maintaining that 70% data completeness threshold for the 2022 and 2023 performance periods. And as a reminder, MIP, CQM, ECQM, and QCR measure specifications include all encounters regardless of payer, and only Medicare Part B claims. Measure specifications are limited to Part B encounters only. Next slide, please. So Molly sort of alluded to some of these changes earlier, but I will be talking through them in more detail now. And sort of as a refresher, previously in the MIPS program, we had 3 measure classifications. Class 1 measures, which are those that can be reliably scored because they meet data completeness and case minimum requirements and have a benchmark. Class 2 measures are those that cannot be reliably scored because they either lack a benchmark or do not meet the case minimum requirements. And class 3 measures are measures that cannot be reliably scored because they do not meet the data completeness requirement. Beginning in 2022, we are introducing a new measure classification, and those are called class 4 measures. Class 4 measures are measures in their first 2 performance periods in the program. Therefore, further sort of broken down into class 4A, which is those that can be reliably scored because they meet case minimums and data completeness requirements and have a benchmark, and class 4B, which are those that cannot be reliably scored because they do not have a case minimum, they do not meet the case minimum requirement or have a benchmark, but are still in their first 2 performance period in the program. So our policy for those measures are that for the first year in the program, these measures will have a 7-point floor established, meaning that those measures that can be reliably scored, the 4A, will be scored from 7 to 10, and those that cannot be reliably scored will receive a flat 7 points. In their second year in the program, these measures will be scored, will have a 5-point floor, meaning for class 4A, those that can be reliably scored, they will be scored from 5 to 10. And for class 4B, those lacking benchmarks or not reaching case minimum, they will receive a flat 5 points. So those are the new measures introduced, the new class of measures, class 4 measures. And class 4 measures will be subject to the data completeness requirement, meaning measures class 4 measures that are submitted that do not meet case minimum the data completeness requirement will be subject to class 3 measure policies. So I will sort of highlight that again, but just to note that new measures will be subject to the data completeness requirement. So now going through some of our previous measure classifications, beginning with the class 1 measure type. Previously, these measures were scored from 3 to 10. And in the 2022 performance period, we will continue to score them 3 to 10 points. However, beginning in 2023, we will remove this scoring floor, and these measures will be scored from 1 to 10. So to reiterate, beginning in 2023, class 1 measures will be scored from 1 to 10. For 2022, they will continue to be scored from 3 to 10. Next slide, please. So class 2 measures, to reiterate, are those that do not have a benchmark or meet the case minimum requirement. Currently, these measures receive 3 points. However, for 2022, these measures will continue to receive 3 points. However, beginning in 2023, these measures will receive 0 points, with the exception of small practices that will continue to receive 3 points. So to reiterate, in 2022, there is no change, and these measures will receive 3 points. However, in 2023, we are removing the 3-point floor, and these measures will be scored 0 for all practices other than small practices. Next slide, please. Okay, so our class 3 measures, which are those that do not meet the data completeness requirement, there will be no change, which, to reiterate, means that class 3 measures will receive 0 points, except for small practices that will continue to earn 3 points for submission of these measures. And again, to reiterate, measures that are in their first 2 performance period but do not meet data completeness requirement will be scored according to this class 3 measure policy. So moving on now to the bonuses in the quality performance category. The first of which is the outcome and high priority bonus. Previously, we were awarding either 1 or 2 points, depending on the measure type. It's outlined in this chart. However, beginning in 2022, we will not be awarding bonus points. So beginning in 2022, there will no longer be bonus points awarded for the outcome and high priority bonuses. Similarly, at the end-to-end electronic reporting bonus are also ending in 2022. So both of these bonus types are being removed starting in 2022. Next slide, please. So we made some amendments to our quality scoring flexibilities policy. And to reiterate what this policy is, it is the policy that states that CMS may truncate a performance period to 9 months of data if available, or suppress a measure if we believe that there is reason to believe that the scoring of these measures will lead to misleading results. So this year, the changes that we've made to this policy are to include, expand the list of reasons that a quality measure may be impacted, and lead to misleading results, and these include changes to the active status of codes, inadvertent omissions of codes, and inclusion of inaccurate or inactive codes to measure specifications. Next slide, please. So for quality scoring for groups reporting Medicare Part B claims, we finalized that beginning in 2022, CMS will only calculate group level quality scores from Medicare Part B claims measures if practices submit data for another performance category as a group. This is to say that you must signal intent to be scored as a group if submitting with Medicare Part B claims. We aren't able to apply this policy retroactively to 2021 and address this in a comment response in the final rule. However, if small practices can submit a EUC application to request reweighting, that is still an option if depending on when the deadline is. I'm hazy on that. Yeah, so for 2022, beginning in 2022, small practices will only have a group score calculated if they submit for another performance category as a group. Okay, next slide. And now I'm going to turn it over to my colleague, Ronique Evans, to talk about the changes in the cost performance category.
Thank you. Next slide, please. So just to provide a little overview of the cost performance category basics, we operate on a 12-month reporting period. All of the measures are claims-based, so there's no reporting requirements to CMS. We have approximately 25 measures in the program. 2 of our more global measures, the MSPB clinician measure and the TPCC measure. And then we have 18 existing episode-based cost measures and the 5 newly finalized measures in this past rule. Next slide, please. So for the 2022 performance year, we are adding 5 new episode-based cost measures to the cost performance category. 2 of these are procedural measures. 1 is acute inpatient measure, and 2 are some of our newly framework episode-based cost measure. 2 are chronic condition measures. Next slide, please. So currently in the CMS measure development process for cost measures, all of the cost measures are developed in-house by CMS. Beginning in calendar year 2022, we will establish a process of cost measure development by stakeholders. And this will be similar to what we see for the call for quality measures. It will include a call for cost measures for earliest adoption into the MILS program during the 2024 performance period. Next slide, please. So with that, I will pass it over to our colleagues in improvement activities.
Thank you, Ronique. In the next few slides, I will be providing an overview of changes to the traditional MIPS for improvement activities performance category under the 2022 final rule. I'd like to note that we did finalize all of the improvement activities policies that we proposed in this year's proposed rule. Next slide, please. First, for a bit of background, the reporting basics for improvement activities have not changed and have remained the same since the beginning of MIPS. There continues to be a consecutive 90-day reporting period. A clinician may gain a maximum score of 40 points, which may consist of either medium for 10 points or high 20 points weighted activities, or any combination of these to reach the 40 points. I would also like to note that our flexibilities for reduced reporting requirements continue for small practices, those in rural locations, and in health professional shortage areas. If you meet one of these designations, the weighting for improvement activities are medium weighted is worth 20 points and high weighted is worth 40 points. Next slide, please. For the improvement activities inventory, we're updating our inventory with a focus on health equity. Specifically, we added 7 new improvement activities, 3 of which were related to promoting health equity. We also modified 15 current improvement activities. 11 of those address health equity. And then we also removed 6 previously adopted IAs because we believe that we found them to be duplicative, and we felt there was an alternative activity with a strong improvements in clinical practice. Next slide, please. We finalized the removal of improvement activities process outside of rulemaking. So beginning in 2022, we will suspend improvement activities if there is a reason to believe that the continued collection either raises possible patient safety concerns or it has become obsolete. Our process will be then to notify clinicians and the public of the suspension, and then we will propose to remove or modify the improvement activity as appropriate in the next rulemaking cycle. If a submitter does attest to an IA during the year the IA is suspended, the clinician would be scored on it, as it is possible they completed an IA in the time period before it was suspended. Next slide, please. For the annual call for activities, we've expanded the required criteria for nominating a new improvement activity. Now there will be 8 required criteria that the new improvement activity must meet in order for it to be considered, which it includes 6 of our existing criteria and 2 new. So as you can see on the slide here, they're annotated which are the 2 new. The first one is that the new activity must not duplicate other improvement activities in the inventory. And then the second is new activities must drive improvements to go beyond standard clinical practices. Those are the 2 new ones. Were in our previous criteria. Next slide, please. Then lastly, we've actually added 6 optional factors for the call for activities for nominating an activity. These are factors we may consider, but they're not required because they're not applicable to all submissions. We do highly encourage submitters to include as many optional factors in their nomination as possible. Next slide, please. And that wraps up the changes for the improvement activity performance category for 2022. I will now pass the presentation to Elizabeth Holland, who will be reviewing the promoting interoperability performance category.
Thank you, Michelle. Next slide, please. Okay, for the promoting interoperability performance category, we again have a 90-day reporting performance period. You must use certified EHR technology or CERT. It needs to either be the 2015 edition or the 21st Century Cures edition or a combination of the 2. We have 4 objectives, just like we have had in previous years. Next slide, please. Okay, so for the 2022 performance year, in addition to the existing special statuses and clinician types listed here in the first column to the left, we'll apply automatic reweighting to clinical social workers and to small practices. There will not be automatic reweighting for certified nurse midwives. In addition, small practices previously had to submit a promoting interoperability hardship application so that they could be reweighted. So now small practices, we will use our data to determine which are small practices, and they will be automatically reweighted for promoting interoperability. But just as a reminder, if any data is submitted for the promoting interoperability performance category, that data will be scored and the reweighting will be canceled. Next slide, please. So this year we have modified the public health and clinical data exchange objective. So we are now requiring MIPS eligible clinicians to report on the immunization registry reporting measure and the electronic case reporting measure, unless they claim an exclusion. Also, for the 2022 performance period, 3 measures that were optional before will remain optional: the public health registry, clinical data registry and syndromic surveillance reporting measures. Those are all optional. If you choose to submit data for one of them, a yes for any one of them, you will earn 5 bonus points. And note that reporting more than one optional measure doesn't earn you any more bonus points. You're limited to 5 bonus points. If you happen to qualify for exclusions for the 2 required measures, you are still able to report on one of the bonus measures to earn the 5 bonus points. Next slide, please. Okay, so we have a couple new things this year. First, I'm going to start with the last. So making electronic case reporting a required measure, we understood that there was some concern that certified EHR technology may not have the capability to do this in 2022. So therefore, we added a 4th exclusion for this measure, in addition to the existing exclusion activity. And this exclusion is only good for the for 2022. And the exclusion is if the MIPS eligible clinician uses cert that is not certified to the electronic case reporting certification criteria at section 170.315 F5 prior to the start of the performance period they select in 2022. So hopefully, if you're not able to report on electronic case reporting, one of the existing exclusions will work for you. But please note that this exclusion that I mentioned is only for 2022. In addition, we are now requiring MIPS eligible clinicians to attest to conducting an annual assessment of the high priority guide of the safety assurance factors for EHR resilience guide. So this is new. It is a yes/no measure. And for this first year, you could answer with a yes or a no. Both are acceptable, and the measure will not be scored. In addition, we used to have 3 prevention of information blocking attestation statements. We have modified this to remove 2 of them, so now there's only 1 statement. It is did not willfully take action, such as to disable functionality to limit or restrict the compatibility, excuse me, or interoperability of certified EHR technology. Okay, now I'm turning it over to Cindy Shi to discuss scoring.
Thank you, Elizabeth. Good afternoon, everyone. The section I'm going to present is a traditional MIPS final scoring. Next slide, please. Complex patient bonus. Because of the concerns of the direct and the indirect effects of the COVID-19 public health emergency, we will continue to double the complex patient bonus available for the 2021 MIPS performance year. So these bonus points would be added to the final score. We have also revised the complex patient bonus beginning with the 2022 MIPS performance year, 2024 MIPS payment year, by limiting the bonus to clinicians who have a median or higher value for at least one of the 2 risk indicators. The first indicator is a hierarchical condition category score. The second one is a proportion of patients dually eligible for Medicare and Medicaid benefits. We also updating the formula to standardize the distribution of 2 risk indicators so that the policy can target clinicians who have a higher share of socially or medically complex patients. And we also increasing the bonus to a maximum of 10 points. So this bonus will be available to clinicians, groups, subgroups Subgroups will begin with the 2023 performance year. It's also available to virtual groups or APM entities that meet the criteria above, and also submit data for at least one performance category. Next slide, please. Redistribution for small practices. So we are implementing performance category reweighting and a redistribution policy changes to put more emphasis on the improvement activities performance category. So which we think should help small practices reach the performance threshold. Beginning with the performance year 2022, when the promoting interoperability performance category is reweighted, the other category will be weighted at quality, 40%, cost, 30%, improvement activity, 30%. When both the cost and the PI category are reweighted, quality and improvement activity categories will be equally weighted at 50%. So under our existing policies, when both quality and PI performance categories are reweighted, the cost and the improvement activity categories will be equally weighted at 50%. So this policy applied regardless of a small practice status. Next slide, please. So Molly already went through the performance threshold rule in the rule highlights at the beginning of the section. So there is more information about this, this topic. 2022 performance threshold. So as required by statute, beginning with the 2022 performance year, the performance threshold must be either the mean or median of the final scores for all MIPS eligible clinicians for a prior period. So to this end, we used the mean final score from the 2017 performance year to establish the 2022 performance threshold as 75 points. Additional performance threshold of 89 points for exceptional performance. Please note that the 2022 performance year, 2024 payment year is the final year for an additional performance threshold for exceptional performance. Next slide, please. Next one is about the performance threshold and the payment adjustment. As shown in this graphic, you can see that the performance threshold for a neutral payment adjustment was raised by 15 points from 60 to 75 points for the 2022 performance year. The performance threshold for exceptional performance was raised by 4 points from 85 to 89 points for the 2022 performance year. The performance threshold for a negative payment adjustment was changed from less than or equal to 60 points to less than or equal to 70 points for the 2022 performance year. This is the end for final scoring section. With that, I will turn it over to our colleague Sophia on MVP topic.
Thank you, Cindy. Next slide, please. Okay, and in this section, we'll kind of go through all of the MIPS value pathway updates that were finalized in this final rule. So next slide. Okay, to start off, we want to touch upon our MVP development criteria. You may remember in the previous 2021 final rule, we established and finalized several criteria in which we encourage stakeholders and also CMS ourselves to use when developing MVPs. So this criteria is to continue to build on that and really reflect some of our current or finalized policies with regards to reporting requirements So one of the items we finalized is that all MVPs must include at least one outcome measure that's relevant to the MVP topic. And if an MVP includes several clinician specialties involved in the, for example, line of service or the team-based care that is being practiced, then we want to make sure there are enough outcome measures that are relevant to each clinician specialty that's involved. We are aware there are instances where certain specialties may not have outcome measures, and so in that instance, we are asking that high priority measures are included when relevant and appropriate. So please be mindful of that, and that really helps to kind of ensure that clinicians who report on an MVP can successfully report by meeting the quality reporting requirements. We do also have within our our MIPS quality measure inventory, several outcome-based administrative claims-based measures that are available, and we want to make use of those within a MIPS value pathway. So we are allowing for the inclusion of those measure types within the quality component of an MVP. And so with the use of administrative claims-based measures, that reduces reporting burden on the clinician's behalf, where because they do not have to actually submit any data on those measures to us, we calculate on the CMS side. In addition, we had previously finalized that QCDR measures can be included in MVPs. We did want to clarify through this rulemaking cycle that all QCDR measures, in order for them to be included in a MIPS value pathway, they must be fully tested at the clinician level, and we must receive all measure testing data by September 1st of the year that the year prior to which the MVP is being going to be proposed for. And September 1st really kind of coincides with the date in which self-nomination ends. So our expectation is that any QCDR that has put forward an MVP and anticipates that MVP being put forward in the near future would submit to us testing data by no later than September 1st of that performance year, prior to the September 1st prior to the performance year. Next slide, please. And to move us further, we also established a timeline in which we would implement MVPs over time, and then we also put forward some participation requirements. So we did finalize that all MVPs will, and some of the MVPs that we had proposed, which were 7, will be available beginning with the 2023 performance year, and that's really to give clinicians and vendors and practice administrators and large health systems time to orient themselves to MIPS value pathways and prepare before taking on MIPS value pathway as they're implemented. Beginning with the 2023 year and to 2025, we have finalized a term that is called MIPS MVP participants, and that is really to encompass the several clinician types that are identified below: individual clinicians, single specialty groups, multi-specialty groups, subgroups, and APM entities. You'll notice that multi-specialty groups has an asterisk next to it, and that's really to indicate that beginning with 2026, as Molly had alluded to, multi-specialty groups will be required to form subgroups in order to report MVPs. So there is a bit of a caveat to the multi-specialty group participation beginning with 2026. Next slide, please. We also finalized within our policies that in order for clinicians or MVP participants to report on an MVP, they must go through an MVP registration process. And so the MVP registration process will occur between April 1st and November 30th of the performance period to report an MVP. And then during that time, a given clinician who would then report as an MVP participant would need to select an MVP, identify a population health measure that's included within the foundational layer of the MVP to report on. Currently, there are 2 available population health measures, and we'll get into those details a bit later, but we are offering the opportunity for clinicians to then select which of the 2 population health measures to be calculated on. And if there's any instance where an outcome-based administrative claims-based measure is available within the quality component of an MVP, and an MVP participant would like to be calculated on that measure to count as one of the 4 measures, that would be the opportunity for them to then register for that measure as well, so we can track to it. After the November 30th deadline, MVP participants won't be able to make any changes to what they've registered for. In a sense, the MVP they selected, or the measures, the population health measure, for example, and they also would not be able to report on any MVP that they did not register for. So it's very important that between that time frame, participants take the time to identify the MVP, and if they need to make changes, they can do so between April 1st and November 30th, but no changes will be accepted after that deadline. Next slide, please. For the third-party intermediaries, we did finalize some policies related to the MIPS value pathways and really how they can support that work. So beginning with 2023, we did finalize that QCDRs, qualified registries, and health IT vendors will be required to support MVPs that are relevant to the clinician types that they currently support. So we are aware that there are certain vendors that only support a single specialty. And so we did not think it was appropriate to just take on the assumption that of requiring that all vendors support all MVPs. We want to make sure that all vendors support MVPs that are relevant to the clinicians they support to report MIPS. So that flexibility is built in there, but we want to make sure that they really help to support this new initiative. And then with that, we also are requiring all QCDRs, registries, and health IT vendors to also support subgroup reporting as well. And we'll get to subgroups in a bit later. In addition to that, for the CAHPS for MIPS survey vendors, we are aware that they only support the CAHPS measure, but there may be instances where the CAHPS measure is included within the MVP and a subgroup may want to report that CAHPS measure. So we have finalized that CAHPS survey vendors should be able to support subgroups who intend to also report the CAHPS measure within the MVP beginning with the 2023 performance year. Next slide, please. Okay, as we previously alluded to, there are 7 MVPs that we have finalized, and here you'll find the clinical classification and the formal title for the MVP for each of the 7 MVPs that we have finalized. You'll notice with the last 3 MVPs that we have finalized those with modification. With the emergency medicine and anesthesia MVP, I believe those were finalized with removal of a QCDR measure that was not tested, or we did not have the testing data to support that the measure was fully tested. But and so those measures have been removed. And then with the lower extremity joint repair MVP, I believe we've added an improvement activity to that. So those details can be found within the appendix of the final rule, but we have finalized 7 MVPs overall. Next slide, please. With regards to the reporting requirements, we have broken it down here by performance categories, as you'll note. So for the first 3 components, we have quality, improvement activities, and cost. For quality, as I mentioned before, an MVP participant would have to report on 4 quality measures, one of which must be an outcome measure or a high priority if an outcome measure is not available. And that's pretty much similar to what we do in traditional MIPS. For improvement activities, the MVP participant will have to select 2 medium-weighted activities or 1 high-weighted activity, or the PCMH if it's available within the MVP. That's also an option. For cost, an MVP participant will be scored on the cost measures that are included in the MVP, and we are being cognizant to include clinically relevant cost measures. So it's not that you'll be calculated as an MVP participant on the entire inventory of cost measures. It's only those that are included within the MVP. And we are aware there are instances where certain specialties or clinicians may be excluded from the calculation of a cost measure, and so there are reweighting policies that account for that as well that are built into our scoring policies. The foundational layer, we have 2 areas. We want to note the population health measures are not considered their own performance category. They are a part of the quality performance category and are wrapped up into that score. Population health measures, there are measures that exist within the quality measure inventory, so they are a part of the quality performance category. So within, as I mentioned before, a participant would select one of the two measures, and that measure will be calculated and scored and rolled up into the quality score. The two measures that are available are the hospital-wide readmission measure and the newly finalized multiple chronic conditions measures. And there's details of both of that measure within the measure appendix of the final rule as well. For promoting interoperability, we are not creating separate standards for reporting requirements for PI under MVPs, the same requirements that are currently exist under traditional MIPS, including the policies around which clinician types are excluded from reporting PI will apply to the MIPS value pathways as well. Next slide, please. With regards to subgroups, we did finalize the availability of subgroups within the MIPS value pathways reporting options. We will limit the subgroup reporting to be available through either MVPs or the APP. Voluntary reporters, often eligible clinicians and virtual groups, won't be able to report through an MVP for the program year 2023 as a subgroup. And that really speaks to some of the operational capabilities that we're still working through. And so that is something we could potentially revisit in the future, but for now we have made that limitation. In order to participate, requirement to participate with regards to subgroups, it is going to be voluntary for the first few years. So from 2023 to 2025, subgroup reporting will be voluntary. If clinicians choose not to report as a subgroup, they can continue to report as a group or as an individual. The subgroups will inherit the eligibility and special status determinations of their affiliated group, even if the subgroup composition does not meet the criteria. So for example, if the subgroup does not meet the low volume threshold criteria at the subgroup level, but they do at the group level, we would always look to the group level eligibility and carry that through to the subgroup. So we will not evaluate the low volume threshold at the subgroup level. And then similarly to the registration process for MVPs, we anticipate that the capability to register as a subgroup will also be folded into the registration process too. So that registration period is also April 1st to November 30th. You will be required, if you are intending to report as a subgroup, to submit some additional information. So that you will have to identify which MVP you plan to report, as well as the measures that we've outlined before in the previous slide. But then in addition to that, you'll also have to identify the clinicians in the subgroup by TIN NPI, and also provide a subgroup name for public reporting. And then from that point, we will take that information through the registration process and then assign a unique subgroup identifier to a subgroup that successfully completes registration. Next slide, please. With regards to scoring, a lot of the scoring policies related to quality align with the policy updates that Zenobia just went over for MIPS quality earlier in this presentation. So please see those slides for those details related to that. We will, for MVP scoring specifically for quality, use the 4 highest scored measures if an MVP participant reports on more than the required number of measures. If an MVP participant does not report any of the 4 required measures for whatever reason, they will receive a 0 in achievement points. We also want to note that if an outcome-based administrative claims-based measure is available and selected through the registration process to fulfill the outcome measure requirement, and for some reason that measure cannot be calculated, for example, the clinician who selects that measure cannot meet the case minimum, the measure will receive a 0 achievement point score if the measure does not meet that case minimum. And I think the slide here needs to be corrected because it does say benchmark. One thing to note here is that we do encourage those clinicians who are unsure of whether they can meet the necessary thresholds to have the administrative claims-based measure calculated for the outcome requirements, that we would encourage you to report an additional outcome measure if it's available or applicable to avoid a scenario where you potentially achieve a 0, because then we would take the higher of the two and obviously count that towards the score. For cost, measures are scored in alignment with traditional MIPS. And it's, again, as I mentioned before, only the cost measures that are included within the MVP are scored. With regards to improvement activities that are of a medium weight are assigned 20 points, while high-weighted improvement activities are assigned 40. So if you choose to do medium-weighted activities, you will have to do 2 to complete the improvement activity reporting requirements. And then if you choose a high-weighted, it's just 1. Next slide, please. With regards to the population health within the foundational layer, the population health as I mentioned before, is selected by the participant at the time of registration. And we have policies that currently exist under traditional MIPS about scoring administered claims-based measures, in which the measure will be excluded from scoring if the measure doesn't have a benchmark or meet case minimum. Those policies will carry through over into the world of population health measure calculation under MIPS value pathways as well. The only exception to this rule is that if a subgroup cannot be scored at the subgroup level on the admin claims measure, they will receive the score of their affiliated group. And so that will kind of work to be a backup for those subgroups for population health measure scoring. And then with regards to promoting interoperability, the scoring is in alignment with what is done under traditional MIPS scoring. The only caveat that we want to include here is that subgroups are not reporting or scored at the subgroup level for promoting interoperability. They are given the score at the group level. So their reporting will also occur at the group level as well. Next slide, please. And then with regards to final scoring, we have policies to determine the final score that will generally align with traditional MIPS scoring performance category weights. The reweighting policies will also align with traditional MIPS. The only exception to that is the quality performance category won't be reweighted if we can't calculate for MIPS eligible clinician. And then also the MVP participant will receive a final score based on their MVP reporting unless a higher final score can be attributed to the MIPS eligible clinician from another reporting option or participation option. So for example, if an MVP participant reports on an MVP, but then also participates in traditional MIPS and fulfills both requirements of both tracks, we would score each and then take the higher of. So there will be an opportunity to consider reporting through an alternative. Next slide, please. And then lastly, with regards to performance feedback and public reporting, we did finalize that we would provide enhanced performance feedback for those that report MIPS value pathways, and we would provide comparative feedback within the annual performance feedback report, the final feedback report, to show the performance of like clinicians who report on the same MVP. And that will hopefully provide more valuable information in helping clinicians make improvements in the care they provide. That is a bit more detailed than what is currently provided under traditional MIPS. With regards to public reporting for MVPs, we will delay the public reporting of new improvement activities and promoting interoperability measures and attestations that are reported through MVPs by 1 year. And we will begin publicly reporting subgroup data beginning with the 2024 performance year on the Compare tool that is hosted by the CMS website. In addition, the subgroup performance information will be publicly reported separately from individual clinicians and group performance information. Next slide, please. Okay, and with that, I will turn it over to Jennifer Harris. Thank you.
Thank you, Sophia. For public reporting, we will be adding additional facility affiliation information. Next slide, please. So currently, CareCompare displays hospital affiliations on clinician profile pages, which connects to the relevant hospital profile page. Moving forward, we will display affiliations for long-term care hospitals, inpatient rehab facilities, inpatient psychiatric facilities, skilled nursing facilities, home health agencies, hospice, and end-stage renal disease facilities on Care Compare. Next slide, please. I will now hand it over to Brittany.
Thanks. Next slide, please. So by way of updates on the advanced APMs for 2022, we only have two pretty minor updates. The first is sort of a technical change that we're making to the way in which we're identifying payee TINs who will be receiving the APM incentive payment for QPs during the 2023 payment year, 2022 payment year going forward. And so what we did here was essentially just say that because we've been doing this a few years and we've gotten better at it, we're expanding the pool of TINs that we're looking to include TINs that have affiliations with QPs during the payment year. So the sort of short version of this is most people or many people will be getting their payments sooner because of this change. And that's pretty much all that's going on there. The other change that's not included here because it wasn't actually a policy proposal that was finalized, but I just want to point out is that Congress actually passed a freeze of the QP thresholds. So for the next two performance periods, the QP thresholds will be frozen at their current levels of 50 and 35%, rather than increasing to the 75 and 50% as was required by the statute previously. So again, the only change is that nothing is changing. We're just going to continue with the same QP threshold we've had for the past several years. Next slide, please. And I'm just going to turn it right over to, I think we have Sandra on today to discuss MSSP and also the APM performance pathway generally. Sandra?
Hi, Brittany. This is Kathleen. I'm going to be reading the slide for the Medicare.
I'm so sorry, Kathleen. Let me turn it over to Kathleen.
No. Thank you, Brittany. So today, everyone, I'll be providing an overview of the Medicare Shared Savings Program final rule policies related to quality reporting requirements and the quality performance standard. Next slide, please. The Shared Savings Program quality reporting requirements for performance year 2022 and subsequent performance years were finalized with modifications to the proposals. We finalized a longer transition to ACO all-payer quality measure reporting by extending the use of the CMS web interface through performance year 2024 for Shared Savings Program ACOs. Specifically, for performance years 2022 through 2024, in order to meet the quality reporting requirements under the Shared Savings Program, ACOs are required to report via the APP either the 10 CMS web interface measures or the 3 ECQM MIP CQMs, administer a CAHPS for MIP survey, and CMS will calculate 2 claims-based measures included under the APP. Based on the ACO's choosing reporting option, either 6 or 10 measures will be included in calculating the ACO's quality performance score. And for performance years 2025 and subsequent performance years, ACOs are required to report via the APP the 3 ECQM MIP CQMs and administer a CAHPS for MIP survey, and CMS will calculate 2 claims-based measures included under the APP. Next slide, please. The Shared Savings Program quality performance standard policies for performance year 2022 and subsequent performance years were also finalized with modifications to the proposals. The quality performance standard is the minimum performance level ACOs must achieve in order to be eligible to share in any savings earned, avoid maximum shared losses under certain payment tracks, and avoid quality-related compliance actions. For performance years 2022 and 2023, an ACO will meet the quality performance standard if it achieves a quality performance score that is equivalent to or higher than the 30th percentile across all MIPS quality performance category scores, excluding entities and providers eligible for facility-based scoring, or if the ACO reports the 3 ECQMs, MIPS CQMs, meeting data completeness and case minimum requirements for all 3 measures, and achieves a quality performance score equal to or higher than the 10th percentile of the performance benchmark on at least one of the 4 outcome measures in the APP measure set, and a quality performance score equivalent to or higher than the 30th percentile of the performance benchmark on at least one of the 5 remaining measures in the APP set. An ACO won't meet the quality performance standard if the ACO doesn't report any of the 10 CMS web interface measures or any of the 3 ECQMs, MIPS CQMs, and doesn't administer a CAHPS for MIPS survey. For performance year 2024 and subsequent performance years, an ACO will meet the quality performance standard if it achieves a quality performance score that is equivalent to or higher than the 40th percentile across all MIPS quality performance category scores, excluding entities and providers eligible for facility-based scoring. An ACO won't meet the quality performance standard if the ACO doesn't report any of the 10 CMS web interface measures or any of the 3 ECQMs, MIPS CQMs, and doesn't administer a CAHPS for MIPS survey. We also finalized our proposal to replace the MCC for ACOs measure with the MCC for MIPS measure in the APP measure set for performance year 2022 and subsequent performance years. Next slide, please. For the next 2 slides, we have included a visual of the APP measure set for performance year 2022 and subsequent performance years. On this slide, the table includes the ECQM, MIPS CQM measures, which would be the first 3 listed, as well as the CMS web interface measures that are part of the APP measure set. As previously mentioned, ACOs had the option to report via the web interface for the 2022, 2023, and 2024 performance years only, and will be required to report the 3 ECQMs, MIPS CQMs, beginning with performance year 2025. Next slide, please. To round out the APP measure set, this slide includes the CAHPS for MIPS and the 2 CMS claims-based measures, which are part of the quality reporting requirements in the measure set and must be reported as well. This completes the Shared Savings Program final rule overview. I'd like to turn the presentation over to Katie.
Great, thanks, Kathleen. We can go ahead to the next slide. Okay, great. This is just a repeat of information we had at the beginning. Thanks everybody for hanging in there with us, and we're going to get over to the Q&A in a minute. But just flagging that these resources are available, as well as where the final rule is posted on the Federal Register. A couple other things I wanted to note for folks, that our QPP participation status lookup tool was recently updated with final 2021 data, eligibility data, as well as initial 2022 data. So encourage folks to go there and check your eligibility status. And if you haven't done so already, please sign up for the QPP listserv. That's how we get most of the information we have out to folks, so please sign up for that. And then I will turn it over in 1 minute to the Ketchum team to help explain how we're going to do the Q&A today. But I did want to just clarify a couple things. Saw a number of questions about 2022 EUC exceptions available. So right now, you will have the option in 2022, since nobody really knows what's going to happen next year. Hopefully things will start getting better, but if clinicians still need relief from participation in MIPS, there will be the Extreme and Uncontrollable Circumstances application available for folks to apply for. So that will be an option for 2022. And then one other thing I wanted to clarify, saw a few questions about MVPs and traditional MIPS. Wanted to make sure folks were, that we were clear that beginning in 2023, the 7 MVPs that Sophia discussed in detail will be available beginning in 2023. But also, as she discussed, traditional MIPS will still be available. We haven't determined exactly when traditional MIPS will not be available, but it will be available in 2023. So didn't want people to panic that it was ending already, only with 7 MVPs available. Okay, so I will turn it over to the Ketchum team, who will explain a little bit about how we will do our Q&A today. Oh, sorry, I got one more slide here. Just wanted to flag that support is available. We do have our small and solo practice, so small underserved rural support. Our SERS technical assistance teams that I know have been a huge help to folks. This support will be available to small practices, so 15 or fewer. And just wanted to note that we will be sending out communications soon, but I think most folks are aware of this, that support and this initiative will be ending as of February 15th, 2022. So we will send out more information soon, but just want to encourage folks, if you haven't already used those resources, please contact them as soon as possible and try and get your data in for 2021 during the submission period beginning in January as soon as possible. And then we'll also have our QPP Service Center is always available and ready to answer any questions, whether they are basic or more complex. So please reach out to them. And with that, I will turn it over to Ketchum to start our Q&A.
Great, thanks, Katie. So we are now going to start the Q&A portion of the webinar. You can ask questions via the Q&A box or through webinar audio. To ask a question via the webinar audio, please raise your hand and we will unmute your line so that you can speak. To submit a question anonymously via the Q&A box, please click Send Anonymously. Otherwise, all attendees will be able to view your question. Finally, please note we are not monitoring the chat box, so any questions submitted through the chat box will not be addressed. Okay, so moving on to our first question. This is about the SAFER guides. So the question is, for the SAFER guides requirement, can you clarify that we only have to complete one of the high priority guide, not all 9 SAFER guides?
Just one, the high priority guide. The 9 are required for hospitals participating in the Promoting Interoperability program, but just the high priority guide is required for MIPS eligible clinicians.
Great, thank you. Our next question, to confirm, the last performance year to receive a positive payment adjustment for exceptional performance is 2022 payment year 2024. After this, even if you perform well, will there not be a positive payment adjustment?
This is Cindy. Yes, it's correct. Yeah, the 2022 will be the last year for the exceptional performance bonus.
Hi, everyone. And this is Katie too, Cindy. I just wanted to add on to the end of that, because I think the first part of that is definitely accurate, that that's when the exceptional performance bonus is ending. But just in case the second part of that question was asking if there would be any positive payment adjustments available, that is, since it's a budget neutral program, the distribution of positive payment adjustments outside of the exceptional performance will be determined based on the number of negative payment adjustments. So we anticipate that there will be positive payment adjustments even after the exceptional bonus ends next year. Thanks.
Thank you. Our next question, does the removal of bonus points in 2022 include the complex patient bonus for ACOs?
So I would defer to my colleague, Dan Reiner. So Dan, can you answer that question for the ACOs? Do we still have a complex patient bonus? Or can we get the answer to the attendee later?
Sure, we can come back to that question and
Okay.
move on to our next one. Okay. Our next question, with the automatic MIPS EUC for clinicians, if a group applies for the EUC for cost only in 2021, is it likely the application would be granted? And I can repeat that question if needed.
Haley, it's Molly. Could you
Sorry,
repeat
Haley.
the question?
Yep, sorry.
Sure. With the automatic MIPS EUC for clinicians, if a group applies for the EUC for cost only in 2021, is it likely the application would be granted?
Well, so I guess just answering broadly, if any clinician wants to request reweighting of one or more performance categories for the 2021 year, as long as they cite COVID-19 as the reason, we anticipate that those would be approved. If that's not what the question, the asker is trying to get at, let us know. Part of the question I heard you reference the automatic EUC policy. So if you're looking for something else, just please reflag it for us. But otherwise, I think that should answer the question. Thank you. Bye. Or thank you.
Thanks, Molly. And I think we have time for one more question. So what date will the APP reporting option open?
The APP should open at the same time all MIPS reporting opens for this performance year. I'm not actually sure what that date is. I believe it's January 1st.
Okay, thank you. And I know that was a quick Q&A, but I do believe that is all the time that we have for today. So we will be concluding the Q&A portion of the webinar. And now I will turn it back over to Katie to conclude the call.
Great, thanks, Kelly. Thanks everybody for joining today. Really appreciate it. And again, sorry if we weren't able to get to your question today, please feel free to reach out to our QPP Service Center to get the information you need and check out our other resources available on the QPP Resource Library. We will have these, the slides are already available, but we'll have the transcript and recording of today's event available on our QPP webinar library in the next week or two. Thanks again. Talk to y'all soon.